Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi, James. We're going to talk about our first cellular therapy product in just a minute, but maybe a few quick fire questions. We've talked about bed making. Do you snooze the alarm, or do you get up with the alarm or without an alarm?
I normally wake up before the alarm, actually. So it's quite rare that I sleep as far as the alarm. That's one thing to say. And if it goes, I usually set it for the latest possible time anyway, so I can't snooze. I need to get going. Yeah.
I asked this question to our friend Kim Margolin one time and was so charmed by her answer. First of all, she doesn't make the bed. I hope that's okay, Kim, that I'm putting you on blast like this. And then she says she snoozes for an hour or so. And I loved that answer. It's so real and human. I said, what about your husband? And she said, what about him? Is he bothered by all this? She's like, no, it's fine. I'm so charmed by it. I actually like that Whoop, you can do just a vibration on your wrist. But I think the problem is there's no snooze for that. So that doesn't work for me. I need to snooze.
No, I normally use Whoop actually, but I can't remember the last time I woke up when the alarm actually went off. But it's getting light at the moment this time of year and all that stuff. So that's my excuse. I go to bed early as well.
All right. So enough about our morning routines. It probably says a lot about us that you get up before the alarm and I like to hit the snooze. Let's talk about Lifileucel, which is now approved in the US, branded under the name Amtagvi. This is cellular therapy, and the Chesney paper from JITC, tell me the year here, 2022 is the one that we're talking about. So let me ask you, as obviously somebody who's very familiar with this data and involved, what is the study schema? What's your take on this study? Can you describe it for us?
Yeah, so it's a little complex actually, in all honesty. And there's various different cohorts to the study which are illustrated pretty well. So, for example, there's a retreatment cohort 3. There's a non-cryopreserved cohort 1. There's cohort 2, cryopreserved, and then there's cohort 4 as well. So it's a little complex. The analysis is basically done in cohorts 2 and 4, so that's really where the focus should be, I think. And then the other quite important point is that this is a non-randomized study, which I'm sure we'll come on to talk about, in treatment refractory cutaneous melanoma. Definition of treatment refractory: everyone pretty much had anti-PD-1, most had had Ipi/Nivo, and if BRAF mutant, then appropriate BRAF targeted therapy. So without necessarily dwelling on that too much, I think the point there is that treatment options in that group of patients, which we all have in the clinic, are really pretty limited. Generally, we would favour a clinical trial if we could. Not everyone's suitable for a clinical trial. And I think that maybe the final comment might be that, in the last several years now, and we haven't really talked about this together yet properly, the data for novel approaches and agents in the refractory space has been really very disappointing. So we haven't really seen much there, I don't think, for a long time.
Could I ask you, for somebody who's listening who maybe doesn't understand cell therapy, 2 questions? You can just bleed them into each other as you answer. The difference between cryopreservation and non-cryopreservation of the cells, and then what does cell therapy actually look like for the practitioner and the patient?
I think that cryotherapy versus non-cryotherapy is really a kind of technical type of question in the first place. What is the best way to do this process in such a way that you can deliver a product? So I see that as being a technical part of the process. one way to think about this maybe is that it's a manufacturing process. So, what you do if you've got a patient in clinic and you think they're suitable for this type of approach, and if we take Lifileucel, actually a piece of tumor is resected, and usually it would need to be sort of a centimetre and a half or so, or bigger, which is just over half an inch in diameter. So that gets surgically resected. It'll often be subcutaneous deposits or lymph nodes, but it doesn't need to be. And in fact, there's some data out of this other sites of resection. All of them seem in principle able to develop products. And so the way that works is it then gets shipped off to Iovance, and then they generate the cellular therapy product. So some of that kind of process is proprietary, it's worth saying, but the bottom line is that the T cells are expanded ex vivo, product is shipped back to you, and then you infuse it into the patient after non-myeloablative chemotherapy and with interleukin-2 to kind of try and stimulate the T cells. So that's it, very quickly what it looks like.
And are you describing it to patients as TIL, as a cell therapy product, or how are you explaining patients what they're exactly getting, what's doing the work here? The IL-2, the cells?
No, so the way we conceptualize it, and patients really like this idea, I think, is that that you've got these immune cells in there, but for whatever reason they're not really kind of doing the job, and then you take them out, you expand them. Reinvigorate is the word that gets used quite a lot, and then you give them back, and then you stimulate them with interleukin-2. And just to quickly take that point, I mean, there have been questions about whether the efficacy that we see, and we haven't talked about that yet, could in part be to something else that's happened, for example, the administration of high-dose interleukin-2 rather than the product. But I think to talk about the efficacy in this trial, you're seeing basically it's between 30 and 35% durable responses. We would have never seen that back in the day with high-dose interleukin-2 alone. Never. It's not even within the boundaries of confidence intervals, I don't think. And then my other point, I mean, I'm a bit too young, as you know, to have ever done much high-dose IL-2 myself. But my understanding of the literature there, and same applies to kidney cancer actually to some extent, is that the people who are getting benefit from cytokines in the old days would almost always have small volume, what you would call biologically non-aggressive disease. And certainly with the Lifileucel cohort, and we could maybe talk about that, that wasn't the case. You had people with high LDH, you had high tumor burden, all these kinds of things. So I just really, I guess, wanted to put that to bed properly in terms of contribution of components.
Yeah, and I mean, I do have experience with high-dose IL-2. I gave plenty of it, but in no means does that mean that I'm older than you. You're absolutely right, though. It's the M1A, M1B patients in that Michael Atkins paper. In kidney cancer, that's a specific population that goes to the lungs, but it's very limited visceral disease outside of the lungs. You really didn't see any benefit in liver, bones, etc. And here in the Lifileucel, it's benefit really in a treatment refractory, highly visceral population. I guess I was goading you into seeing if you describe this therapy as TITS therapy, which is sometimes how I tell it to patients, tumor infiltrating T cells. I say it's TITS, but we couldn't call it that. So we renamed T cells as lymphocytes. And so it's TIL therapy.
So no, I haven't so far, but maybe that's something with appropriate patient selection. I could think about. Yeah, so that's a nice point.
So at some point we'll talk about this reinvigoration, but maybe I'll put a pin in that and we can talk about it later. Obviously Steve Rosenberg has been doing this for going on 3, maybe 4 decades at the NIH, the 80s, 90s, 2000s, and then 2010, so 4 decades. And proprietary or not, the process that he used was pretty straightforward. Take a tumor, there's some lymphocytes in there. It's just we're in the wrong balance. We have more tumor cells than lymphocytes. So then you just fragment this with the scalpel. You fragment this tumor into a 96-well plate. In that 96-well plate, you give it growth factor for the T cells. The tumors with no real intervention will die away because they're just not getting the nutrients and the factors to maintain them. And then you reculture and you just propagate this culture until all you have are really those T cells. Sounds like somebody's backing up there in London. Or is that
That's your end, but anyway.
It wasn't. It wasn't. Was it me? It's funny. Anyway, so those T cells that get propagated are then multiclonal, no idea what they're recognizing, but they should be recognizing something, and you expand them. And then you can do all sorts of things with cytokines to try to expand more of a CD8 population than a CD4, et cetera, et cetera. And that'll be the next versions of TIL, I think, that we see coming, which are more of these sort of modified ex vivo TIL to get a better batch. Having said all of that, okay, so we talked about the schema. We said it was non-randomized, the contribution of components. This is likely to be real work by the T cells. The IL-2 is just a sprinkling, if you will. Back in the old days, those responses that you would get with IL-2 were in patients who took a real quantifiable amount, and then they did it again, a few weeks later, and then again. It wasn't just 1 or 2 doses. And here with the Lifileucel regimen, it's not necessarily that you have to take 15 doses. In fact, it might even cap out at 6 doses or so. And then probably very few of those patients actually got 6, I think, right?
Yeah, no, that's right. Maximum of 6. I think from memory, might need to fact check this. Actually, the median was about 5. And
Okay.
I mean, we did the study, and actually in a poster somewhere, I've already forgotten where, but I can see myself standing in front of the poster now. We actually looked at whether the number of doses of IL-2 seemed to be relevant for efficacy, and it didn't. But I mean, you made some interesting points there, and one is the sort of polyclonal nature of this, I think, and it may well be in the future. And these kinds of attempts are already underway to really try to understand, if you like, quote unquote, rationally, what are the important T cells that are in there? And that's great and that's important. But at the end of the day, this is absolutely firmly rooted in Stephen Rosenberg's and colleagues' seminal work, I think, without question, over several decades. I think maybe the thing here is that you've got a turnaround time of only about 21 days to generate the product. That wasn't really the case, at least not always historically. And you've got a supply chain. It sounds trivial, but actually it's important. This has been a treatment that's been delivered. This was a global study at multiple centers throughout the world with a 21-day turnaround. So it's the feasibility, I think, to some extent as well, and the deliverability of this. Not at every hospital treating cancer, but certainly that most hospitals, I think, have got the ability to deliver this treatment if it's available.
So you make a good point there about access and scalability. Any concerns about reimbursement for this type of therapy?
Yeah, I mean, reimbursement's a complicated subject, obviously. I mean, just to get in front of that maybe slightly and say, well, the FDA have approved this treatment based on a non-randomized study. That's great. Will other regulators around the world take the same view or not? I think we will have to say. There's loads of examples of non-randomized studies more broadly that have led to regulatory approval. It's obviously easy to make comments about overall survival and not having a randomized study and being unable to demonstrate that. But here we are now. But I mean, I'd like to hope that the regulatory processes here are more akin to the kinds of regulatory processes we've seen with CAR-Ts, for example, in hematology. And the reality here is that had there been a standard of care, just for the sake of discussion and argument in this study, what would it be? And B, maybe the only thing that people could agree on globally, honestly, and I hesitate to say this almost, outside the context of a clinical trial, would be cytotoxic chemotherapy, a kind of dealer's choice type of thing.
Yeah.
And had that been the case, would it even have recruited? Right. Would it? Because there's no way you could have blinded it, obviously.
Right.
So that to me would mean that everybody would just walk away from the control arm almost immediately, I think. So again, it's nice to make these kinds of comments with the benefit of hindsight, but the reality is that would have been quite difficult. And then reimbursement, I mean, fragmented around the world, fragmented within Europe. So you have a central regulator, EMA, in Europe, but every country in Europe will have different reimbursement rules, and that's the case around the world. And I think that's a subject of a discussion in its own right, in a sense, but different payers, I think, will look for different things.
Yeah, that's the issue I think we're going to see already. Maybe we've already seen it, or we will see in the US, is with different commercial payers, obviously our structure is different than other places in the world, but just because something has approval doesn't mean commercial insurance will necessarily be streamlined in covering it. And there are essentially two batches that need coverage. It's the surgery and the manufacturing of the T cells, and then it's the chemotherapy and the treatment and the IL-2 portion that need coverage. And we hope that American insurance companies will look at that as one umbrella coverage. If we're starting down this path, as I used to say to people with high-dose IL-2 therapy alone, I realize now it's coming full circle, we are on a rope bridge across a canyon that's breaking behind us. So you can't cover the surgery and the manufacturing and then say, well, we're not going to cover the actual infusion of this product. That's nonsensical. You got to do the whole thing. And the quick turnaround speaks to the ability to say this is one linear therapy. Can you say something, even if just brief, about duration of response?
Yeah, but before I do, I'll pick up that last point because it's a really good one. I mean, I absolutely see this as a package of care, and with various different components and various different people involved in delivering the care. That's absolutely critical. And I say this a lot, but I think about it, and when I talk to patients about it, a bit like a bone marrow transplant. It's not as toxic generally as having a bone marrow transplant, but it is a package of care. And so then again, from a reimbursement perspective, people pay for bone marrow transplants all around the world. They're used to doing it. We've done it for decades. It sits more easily for me from a reimbursement perspective in that way, rather than the kind of reimbursement we've been used to with drugs. So I think that's a nice way to look at it. And maybe if you want to, and I'm not a health economist, try and understand the level of benefit for the cost that's going in, because that's what health economists actually do. So duration response. Yeah. So in the Chesney Jitsi paper 22, the median duration of response hadn't been reached with a decent amount of follow up. And then just to say something maybe about the median OS, because I guess they're linked. That was around about sort of 14 months or so, and looking like it was beginning to flatten out, although I think you need to be a little bit careful there. But I mean, if you look at the swimmer plot in the paper as well, there are a lot of ongoing responses, certainly beyond the 18 month, 2 year mark. So there is response durability associated with this treatment. I think that's uncontroversial.
And that OS that you're describing really, in this refractory population, we have nothing else that really can generate a year plus median OS. That gets me to maybe the kind of final point, and then perhaps we can do a friendly wager. You made the point that there were some concerns that this was non-randomized, but what would you have randomized it to? And had it been cytotoxic chemo, wouldn't patients have been unsatisfied with that, perhaps dropped out, et cetera? The US FDA certainly can approve things on the basis of non-randomization, but they require a confirmatory study. And here, I think you and I are familiar, the confirmatory study is Tilvance. Tilvance 301 might be the actual number. And it's a randomized phase 3 study in the frontline setting of TIL. You'll have to remind me if it's plus Pembro versus Pembro alone, maybe for contribution of components. That's why they needed it to be TIL plus Pembro. And then the control arm there gets a crossover, and all the caveats. We'll have another podcast dedicated to this trial itself, but that will be the confirmatory randomized trial, whether or not you like that control arm or not, right? I mean, I think we can not like that this was single agent and got approved that way, but there's a safety check here that it's getting moved up in line of therapy in a randomized phase 3. So that's great, right?
Yeah, I mean, it's a whole separate conversation, I think, talking about Tilvance 301, but I think it's a reasonable thing to do, no question at all. You could try to criticize the control arm. That's one thing. There's lots of criticisms you could make if you wanted to. But I think if you think the patient perspective, you either get your anti-PD-1 with your TILs as your first-line treatment option, or you get your anti-PD-1, and if then that's enough for you, great. If you don't, you get to have the TILs afterwards. So the idea of adding something to anti-PD-1, we're quite happy with that, and we have been for several years. And the question for me on efficacy is, what's the delta going to be? It's really that simple on the upside. We used to talk about deltas on the upside for Rela for IPI, that we spend loads of time talking about that. So what's the delta on the upside? And we haven't talked about toxicity, but then the other part of this is obviously going to be, what is the price of that? And just maybe quickly on that, because I didn't really discuss it in detail. The patients come into hospital, usually sort of 10 days, something like that, to have the chemo, to get the TILs, to get the IL-2, but in appropriately selected fit patients, that is an absolutely doable thing. Yes, it's intensive, but it's something that absolutely can be delivered, I think, in practice.
And the nomenclature, that we tend to ascribe to it is they come in and chemotherapy starts on day -7, and then it's chemotherapy for those 7 days, -7, -6, all the way to day -1. Day 0 is your T-cell infusion, and then day +1 or day 1 onwards is your high-dose IL-2 and recovery from non-myeloablative cytopenias. So yeah, maybe 14 days or somewhere approaching 21 days for a turnaround, depending on bone marrow recovery, but very reasonable. I agree with you, very reasonable. You will have to have some cytokine trained nurses, cell therapy, but you don't need a GMP facility to do that final rapid expansion. The product is coming to you ready to infuse, which is great. Okay, so how about, as we wrap up here, how about a friendly wager? Let's do a few. Let's do a few wagers, whether it's a Guinness or real money or who pays for the next taxi ride or whatever the next time we're around each other. What is the next country to approve Lifileucel?
Yeah, I don't know. I honestly don't know the answer to that. And sometimes some European countries have, Switzerland's a good example of that. They're slightly outside, the kind of the European regulator. So I'd love it if it was us here. And I think I'm obliged to say that, but I'm not sure that'll be the case.
I wager that it's going to be Australia. I think they have a
Yeah,
machine.
you sound like you got insider knowledge.
Not at all. I think they have a machinery that works very effectively there to get, melanoma drugs and therapies approved. So that's my wager. When do you think UK will have it approved? Will it be in 2024 or it will be in 2025?
I think more likely first half of 2025 will win well.
That's too broad. You got to narrow it down to like a 2-month range.
Q2 2025.
Okay, a 3-month.
Is that all right? That's a 3-month range.
Okay,
it'll be on my birthday, May. I'm not going to say the exact date in public. May 2025.
I feel like I've missed a happy birthday opportunity then. Okay, so then I'm going to say, you said Q2, which is March, April, May. No, January, February, March, April, May, June. I'm going to say July 2020.
All right.
But that's a really long time for your patients to wait. Okay.
Yeah, it is.
It's too long probably for this good therapy. Okay, well, maybe that's it for TIL, Lifileucel. Anything else you think we missed that's worth mentioning?
No, I think there's lots that we can talk about, but I think the main thing is that, there's a clear signal there in the refractory space. We haven't seen anything that can do that. I suspect we'll start to see more from this type of approach, not just in melanoma, but other cancers in the next few years. So I think for me, that's one of the important landmarks with this therapy, and also the FDA approval. That was really important.
Great. Thanks so much.
Thank you.